So today we've kept the title purposely vague, just to not give too much away. We're going to present a case of a patient that's been managed in the large vessel vasculitis clinic at Imperial. And before we start, we just want to give thanks and acknowledgement to Dr. Deepa Gopalan, one of our consultant radiology colleagues who's kindly selected, reviewed and provided the images that will be used in the presentation today. And also to Dr. Andrew Porter and Dr. Taryn Youngstein, our two large vessel vasculitis consultants. So I will start by just presenting the case. So this is a 47-year-old female who initially presented actually back in 2018 at her local hospital. So she was managed down on the south coast with a history of breathlessness, dizziness, and severe pleuritic chest pain. Of note, her past medical history included previous hysterectomy for menorrhagia. She also had hypothyroidism and an epigastric hernia, and she was on levothyroxine. She had no relevant family history, and she worked in administration. She was an ex-smoker, social drinker, and no history of drug use. So with that history, she went on to have a CTPA and was diagnosed with an unprovoked PE and treated with rivaroxaban. And she essentially remained under the care of the local respiratory hematology doctors for the next 2 years, but essentially had worsening breathlessness and ongoing pleuritic chest pain, which is a bit unusual 2 years after the event and having been treated. So she was referred to the pulmonary hypertension service at Imperial in 2020. And by that time she was WHO class 3. So they kind of reviewed the history again, noted there was possibly some suboptimal medication adherence, so switched her to edoxaban. They carried out an antiphospholipid screen on direct oral anticoagulation, so results were not reliable, but she was lupus anticoagulant positive, but beta-2 glycoprotein and anticardiolipin negative. She then underwent sort of a barrage of investigations, including right heart catheter, VQ scan, CTPA, and PET scan eventually. So the right heart catheterization showed at the time she wasn't actually meeting the ESC criteria for pulmonary hypertension. She had mean pressures of 22. So she was diagnosed with mild pulmonary hypertension by World Society of Pulmonary Hypertension criteria. I now want to just have a look at her VQ scan. So as you can see, so we've got anterior and posterior views. The top half of the images, for those who are unfamiliar, is the perfusion, and the bottom half is the ventilation. So we can see that she's got completely absent perfusion in the right lung with preserved corresponding ventilation at the bottom. So this is an image of this is a CT image of the patient. And as you can see, I don't trust myself with a pointer, but the red arrows demonstrate that occlusion of the right pulmonary artery, and the yellow downward arrow is showing that she's developed multiple bronchial collaterals, which is interesting, just thinking about the chronicity of what's been going on with this patient. The CTPA reported that there was, given the unilaterality of the features, that one of the differentials could be a vasculitis, and she therefore eventually went on to have a CT PET, which I'll go on to show in a moment. But this image shows on the left CTPA with volume rendering, and on the right MR angiography, and you can see again the red star demonstrates the occluded right pulmonary artery. And this was her CT PET, so unexciting, essentially showing no active vasculitis. And for reference, the red arrow points to myocardium with physiological tracer uptake. So on this basis, and for ongoing symptoms, she was referred to Papworth for an endarterectomy, and this was now March 2023 for chronic thromboembolic disease with mild pulmonary hypertension. Intraoperatively, they noted that her tissues were felt to be very abnormal, fibrosed, thickened, and her right pulmonary artery was completely occluded and could not be instrumented at all. So a sample was taken for histology, which showed intimal thickening and medial inflammation in the pulmonary artery vessel wall, mostly lymphocytic, with a collection of macrophage giant cells, which with the findings in keeping with Takayasu's arteritis. And so she was from there referred back to Imperial to the large vessel vasculitis clinic, which is where she was then seen in June 2023. So again, the history was revisited, and it was noted that systemically, other than fatigue, which is understandable given her breathlessness, she didn't really have many systemic symptoms at all. No fevers, she didn't have any night sweats or weight loss. She didn't report any upper or lower limb ischemic symptoms, and other than Raynaud's phenomenon, she had no features of a connective tissue disease. Prior to the unprovoked PE in 2018, she had no history of arterial or venous thromboembolism or recurrent miscarriage. So she underwent a number of additional investigations, including autoimmune serology, which was all normal. We didn't repeat her APLS screen because at this point she remained on direct oral anticoagulation and it wouldn't have been interpretable. Of note, her inflammatory markers were actually completely normal. She had a CRP of 2.4 on initial presentation to the rheumatology team. So it was felt on balance that she had Takayasu's arteritis. So a diagnosis was made and a decision to treat was made on the basis of the biopsy result because, as I said before, this lady was never really unwell with systemic symptoms and her inflammatory markers were normal. So she was then initially commenced on prednisolone, and this was then followed up with initiation of methotrexate. So she carried on with this combination, and then about 6 months after initiation of methotrexate, she developed a chest infection and then sort of just self-discontinued treatment as patients sometimes do. We then saw her again towards the end of August 2024. And at this point, she'd been off treatment for approaching 4 months, and she was very, very unwell. So she was systemically ill. She was having fevers, nightly sweats, generalized joint pains, and just feeling awful. And of note, on repeat blood test this time, her CRP had now risen to 47 and her ESR was 83. So she's now mounting an immune response. So we made a decision to repeat her PET-CT given these new symptoms, and this demonstrated active vasculitis involving the ascending thoracic aorta, going into proximal arch and left common carotid, and involving the main pulmonary artery and also including the atrophic right pulmonary artery. And I'll just now show you some images to demonstrate this. So so image A shows her PET, and you can see she's got intense avid tracer uptake in the aorta, which is highlighted by the green arrow, and in the pulmonary artery, which is highlighted by the pink arrow. And then in image B, you can see some uptake in the lungs, and the corresponding CT shows some ill-defined opacification in the right lung. So she was then seen again to initiate another course of prednisolone and resumed on her methotrexate. At this point, we referred her to the respiratory team because of progressive ground glass changes and her worsening symptoms, and also a lung function test was repeated, which noted that her lung function had also deteriorated. So a decision was made to perform a bronchoscopy to exclude infection. So she didn't have any infection, and cytology just showed mild acute inflammation. And so given the respiratory involvement, she was escalated to mycophenolate, which unfortunately she didn't tolerate very well as the dose was escalated. And so she was then switched to tocilizumab. And that was in February 2025. So she had some more repeat high-resolution CT chest imaging, which showed worsening ground glass changes in the right lower lobe. Parenchymal changes are not common in Takayasu, so at this point wanted to make sure she didn't have a small vessel vasculitis. So repeat anchor testing at this point was negative. So again, another decision was made to repeat bronchoscopy, but infective causes could not be found. And at this point, she was quite heavily immune suppressed. So I think looking for infection was a sensible thing to do. So we then escalated her treatment to cyclophosphamide as she had progressed on tocilizumab, mycophenolate and methotrexate. So as of last month, the patient is actually doing very well clinically. She's had resolution of all of her systemic symptoms, improvement of her respiratory symptoms, and she's now on the 4th cycle of cyclophosphamide. So this slide just highlights a summary of her treatment. So you can see her escalated or progressing through methotrexate, MMF, tocilizumab, and now her being on cyclophosphamide. Just for the non-rheumatologists, I thought I'd just quickly run through the standard approach to treatment in Takayasu as per the EULAR recommendations of 2018. So these patients are initially managed with high-dose oral glucocorticoids, and then disease-modifying anti-rheumatic drugs. In relapse disease, we usually increase the oral glucocorticoids and then consider escalation to tocilizumab or an anti-TNF. And in patients with severe life-threatening disease or progression, we can give cyclophosphamide, and sometimes we add rituximab to allow lower cumulative doses of cyclophosphamide to be given. So now I'll hand over to my colleague, Dr. De Silva, who talked to you about pulmonary arteritis and Takayasu.
Thank you. So pulmonary arteritis and Takayasu, although thought to be rare, there is a wide variation in incidence across studies, and this suggests that it may be underreported. And interestingly, in autopsy studies, the rates are even higher. So this suggests that there perhaps is clinically silent disease in a proportion of these patients. Symptoms are often insidious. They can be very non-specific, and this can lead to delayed diagnoses. And some studies have reported delays of up to 11 years. Ultimately, a diagnosis is heavily based on imaging. And in the early phases of the disease, we tend to see changes in the arterial walls, enhancement, thickening, and stenosis and inclusion tend to occur later on. Pulmonary parenchymal changes can occur, as in this case, and have been reported in studies. Can be as a result of pulmonary infarction, but not necessarily the case. And importantly, pulmonary hypertension does occur in a significant proportion of these patients, and one study has reported 42%, and it is a poor prognostic factor. This is a case series of pulmonary arteritis put together by one of our colleagues from this institution. And as you can see, all three of these cases were initially diagnosed with PE. And in two of these cases, there was a significant time period up to the final diagnosis, so 3 years in one and 7 years in the other. All three cases had elevated inflammatory markers, so that was a bit of a clue. And the key part here is that on retrospective review by our vascular radiologists, there were actually features of pulmonary arteritis in the initial CTPA in all three of these patients. So in summary, pulmonary arteritis, it is a challenging diagnosis. Rarely it is the first presenting feature of Takayasu arteritis. Thrombosis may coexist. And as we know, acute vasculitis is prothrombotic. And this can lead to challenges in endovascular procedures, especially in the presence of active inflammation. Persistent symptoms despite PE treatment should raise suspicion for alternate diagnoses. And in the case of pulmonary embolism, symptoms should generally completely resolve within a few months of anticoagulation. So that's another red flag. And atypical PE presentations, such as in this case, and also in cases of recurrent PE where there are no risk factors, should warrant specialist imaging or even an imaging review to assess for the possibility of pulmonary arteritis. Early diagnosis is important because it leads to early treatment, and that can prevent progressive vascular damage later on. We monitor treatment response, usually by serial MRA, and as well as cardiac MRI. Pulmonary arteritis should be considered in all cases of unexplained pulmonary hypertension, and it is important to screen for systemic inflammatory disorders in these unexplained cases and atypical cases because there can be clues, and this can be done through systems inquiry, asking about constitutional symptoms as well as biochemical markers of inflammation. And lastly, despite the advancement of imaging, it is still important to pursue a tissue diagnosis where possible, and especially where there is diagnostic uncertainty. These are our references. Thank you very much. We're very happy to take questions.
Fantastic. Thank you very much. So Jason, are there any questions online? I think we've had the laptop's gone down. Any questions in the room? So while I'm waiting for the online questions, just to say it was very challenging, this case, because I wasn't sure that we made the right call, but the histology was there, and I think some people are laughing in the audience, and so I was upset for her, but sort of glad when she eventually did come off medication and then flare, that it was the correct feeling to get on and treat, because it certainly wasn't obvious. We've got one question online, Jace. Okay, we've got a question in the room. Okay, we've got someone with their hand up on the call. So do you want to? Jonathan Healy. Hello.
Yeah, please go ahead.
Hi, thanks. That's a great morning and certainly a great presentation just now. I was just wondering about the progression to pulmonary hypertension in unilateral disease. Do you have any ideas to the proportion of patients who would progress to that and rate of progression?
Yes. So that's difficult to ascertain fully, because we do have several other cases, as you've seen. Most have been bilateral, but we do have unilateral. The chronicity of this was quite long, and I think that's the issue. So she'd been unwell for some time with this building, and I think that's how she ended up with such high pressures and such extraordinary imaging at the start. But no, I actually what proportion, because I think we're not screening for it, and I think it's very rare that we pick up pulmonary hypertension as presenting feature, and we have no cases where patients out of the whole cohort that we have, which is several hundred patients with Takayasu, we don't have any that have developed pulmonary hypertension during the course of the treatment, I don't think. So it is an unusual thing, and certainly unilaterally is unusual. So she must have had this for a while and it was brewing. And that's why the description when the surgeon from Papworth rang me was that the pulmonary vessels were rubbery. They were really, really unusual. They'd not seen something like that. So they just took biopsies to see. They thought it might in fact be a tumour or something. They weren't sure. They certainly didn't expect to see inflammation. So they were surprised by the biopsy. And I think it highlights as well how hampered we are with the lack of ability to biopsy the vessel wall in large vessel vasculitis, except in the temporal arteries, because you see these cases where the PET is negative and she had no inflammation peripherally, but in fact almost certainly had she did have a large vessel vasculitis. I hope that answers your question. Yeah. Microphone there. Sorry, for those at home, we've got people, or at work, we've got people in the room with questions.
In this case, is the supposition that the PE was formed at the site in the pulmonary artery, or that they were pro-inflammatory, or potentially, in fact, that there wasn't a PE, but it was an acute stenosis in the pulmonary artery?
All three of those, if you look at our cohort. Okay, so some were misdiagnosed as PE, were never PE when we went back and retrospectively reviewed them. There was no clot, it was clearly vasculitis. And when you do the CT reconstructions, you can see that much better. Then there are some who get clot forming in the narrowed lumen with an inflamed endothelium, and some who do also just have a clot there, but the most of them are the middle ones. So there's inflammation of the vessel and there is some stasis of blood and clot inherent there. So there's a combination of the two.
And Taryn, do you see in other cases, if you have isolated pulmonary involvement, that you have a lack of systemic response? Is it something about the where the disease is affecting that you have a lack of systemic response, or do we not know? Well,
this is the horror story that we are dealing with at the moment. We have seen a number of cases over the last 2 years, Andrew Porter and myself, of patients who have almost certainly got large vessel vasculitis, who have a completely normal CRP and the PET is negative. It proves very difficult for us to know when to treat and when not to treat, and serial MR imaging has been helping us, as well as ultrasound. It is recognised. We know from your talk, Jason, that the FDG ligand has limitations and it is not 100%. And I think certainly in the smaller vessels, so the medium vessels and the coronary vessels, we can't use PET. Even cardiac gated, we often don't pick it up. We've had several cases of biopsy. So at cabbage, the vessels have shown extensive inflammation consistent with large vessel vasculitis or medium vessel vasculitis with giant cell infiltration in patients who have had a normal CRP pre-operatively. We also see that in patients who have IgG4-related disease and coronary arteritis, where we increasingly seeing that pattern in a sort of middle-aged male that's had a heart attack, and they've done a cabbage and they found IgG4 in the vessels. And I think that's where using the fat attenuation index with the PCAP might help us a little bit. I think it, you know, advances in imaging and better PET tracers, which you're going to discover for us, Jason, is better. We have another question in the room.
Thank you very much, Beth. That was a very good presentation. I'll pose this question to everybody. It's quite a pragmatic question. I have two, actually. First one is, when would you re-image after cyclo? Because you mentioned that the patients had 4 cycles, but you've already had imaging to show an improvement. So at what point do you re-image?
So I don't think she needs imaging at the moment. She's extremely well. So we tend for Takayasu large vessel, we tend to do every 6 months an MR angiography. And then if once they're stable and well, we go to a year. So if there's no treatment change and they're well, we'll go to a year. And then when they're really well, we'll go to 2 years surveillance. That's not in the guidelines. So that's just what we do. It's very unusual for us to image sooner than that. So at the moment, I don't think we would need to image, but I almost never do a repeat PET. And we were talking about, Dr. Porter and I were talking about this last week. I don't know why I repeated this lady's PET. I was glad I did, but I can't really say why. I think it's the first repeat PET I've ever requested in this cohort. So it was just one of those things. But I think it has been very helpful for us, but we certainly don't use serial PET imaging in this context. Well, not FDG anyway.
But you did have a big inflammatory, like CRP rise.
Yeah, she had a chest infection. I can't explain. I don't know. I have no idea.
Another question.
Can you do your microphone for home? Sorry. Thank you.
Just a quick follow-up on the question, because I think we are all thinking about that in practical ways. I think in the first presentation you mentioned that the patient can still be in clinical remission, and then you scan them and then you see inflammation. So what do you do in those cases? Would you switch treat? Because this is the questions I think all of us are dealing with in our everyday clinical practice. So that would be my question. Yeah, thank you.
So you're asking whether we act on active imaging in PET imaging or just in general imaging? They are different.
Yeah, I think it was specifically in PET, but I would like to hear your answer if you're.
So we have not ever found a correlation between the PET positivity and this follow-up scan in patient on treatment and active disease. So there was a very big retrospective review of this that was presented at Vasculitis 2023, I think it was, or 24 in Barcelona, where they showed data from the NIH where they had looked at exactly this question. There were patients in whom were in complete remission who had significantly positive PET scans still. There were patients in whom they could do histopathological specimens where there was PET negativity and inflammatory markers are normal that had ragingly active disease. So it is, we don't have that knowledge. What we do know is that people base treatment decisions on frequent PET imaging in patients on tocilizumab in particular and steroids. Some patients will have completely suppressed signal, like Salma showed on that PET scan, which was done after several months of tocilizumab infusion, which the signal had completely switched off. We know, all of us, from the disease that signal being switched off does not mean that if we could biopsy, we wouldn't see inflammation within those vessels. So we can't be guided by that. If it's negative, it doesn't tell me anything. If it's positive, I then have to look at the patient and say, okay, what's going on here? What are the inflammatory markers looking like, etc. Now, that obviously leads to the significant issue of using IL-6 inhibitors. So for cardiologists who might not be that familiar with it, it makes your CRP normal, it makes your ESR normal, it makes your platelet count normal. There is no marker that we can follow that is currently clinically available. So that makes the challenge difficult, and that's why we use it in combination with MRI so that we can look for the vessel wall edema. I think we're going to have a break soon. One more question. Is this Harry, who initially saw this patient? So this is Harry, who was our registrar, now our research fellow, and I think he clerked the patient in when she first ever arrived. Harry.
Yeah, hi, thanks. Great presentation, and yeah, it brings back memories. Um, great that she's doing better on cyclophosphamide. I guess my question really relates to maintenance treatment, given the fact that she's appeared to be refractory to most agents now. What's the plan moving forward?
Oh, we haven't got that far yet. I think we may go back to methotrexate maintenance, because actually she did very well on that. Let's see how she goes. The lungs were the biggest reason why we went ahead with cyclophosphamide, I think. So I think probably we'll do methotrexate back again. We'll see how she gets on.